Justin Pottinger, consultant haematologist, and today I'm going to show you installation of intraventricular chemotherapy into an Ommaya reservoir. The video you're about to watch covers the specific steps involved in doing intraventricular chemotherapy. It doesn't cover the basic steps involved in intrathecal chemotherapy, including the safe prescription, receipt, checking and delivery of chemotherapy. That's covered in our video on standard intrathecal treatment. In addition to the information given in these videos, your organisation may also have specific requirements for WHO checklists before invasive procedures which you should follow. In very rare occasions, patients we find difficult to access the intrathecal space for either reasons of body habitus or previous spinal surgery, and in those cases we arrange for insertion of an Ommaya reservoir by a neurosurgical team. The Ommaya reservoir is a subcutaneous port with a catheter that runs through the skull vault and directly into the ventricle. Important things to note when doing intraventricular as opposed to intrathecal chemotherapy are that the doses of chemotherapy required are half of those required for an intrathecal, and that the intrathecal policy for your organisation will need to be updated to have an addendum to cover the use of an intraventricular device. Key differences to be aware of before setting up for intraventricular chemotherapy are that your organisation will require to access a specific kit to allow this to proceed, namely the NR Fit compliant butterfly and a supply of NR Fit compliant syringes which may be available from your pharmacy. The procedure itself requires specific training by an experienced practitioner, and over and above that given for intrathecal training.
Okay, so we're just going to clear a bit of an avenue across the top. Patients can sometimes do this at home, it depends on what you're comfortable with, alright? Just got a bit of a feel, so we've got it all uncovered. Right, lovely. Squirt him on. This only needs to be popped on loosely. Use only to stop any fingers getting in, and we use it just to spread across the top.
Prior to arrival, the area has been shaved and EMLA cream applied to provide local anaesthesia without the need for injectable lidocaine. The area is cleaned and a pre-prepared sterile field applied. Checking for any discomfort over the reservoir, any erythema or suggestion of infection from previous injection, and also pressing the reservoir gently to bring CSF into it if it's been allowed to decompress. This is a NR compliant butterfly needle with an NR compliant syringe attached. So with gentle pressure the reservoir is accessed and CSF can be withdrawn. I know that the volume to be instilled is 1.5 ml, and so I plan to instill 1.5 and another 1.5 ml as a flush, and so I withdraw 3 mils of CSF, leaving the patient volume neutral at the end of the procedure. The CSF is, as always, sent for cytospin. Note, I'm keeping the level of the open end of the device below head height. I'll then connect the intraventricular chemotherapy. Having connected the intraventricular chemotherapy, I now ensure no air bubble can be instilled, and then with slow constant pressure the chemotherapy is injected intraventricularly. Drawing out any air bubbles that appear and allowing them to float to the top of the syringe. You okay there, Mr. X? The loose end of the device below the height of insertion. And now using my pre-prepared sterile saline, again ensuring no air bubbles in the system. I'm now going to instill 1.5 mils. This is to flush the Ommaya reservoir, to put the chemotherapy into the ventricle, and also to leave the patient in a volume neutral state at the end of the procedure. Disconnect, and then applying gentle pressure, needle is withdrawn. Gentle pressure for a minute or so, and so at the end of the procedure all that is required is a plaster. Key points to note with this procedure are the positioning of the patient, which is different from an intrathecal chemotherapy, the volume and dose of chemotherapy to be instilled, the need to draw up a flush of sterile saline, and the need to use specific needles, syringes and butterflies. During the procedure, important to avoid instilling air bubbles into the intraventricular space, and so tapping the syringe to release air bubbles to the top is important, as is positioning the loose end of the butterfly between syringe changes to make sure that the butterfly is always below the height of the reservoir to prevent air leakage. Having now completed the procedure, aftercare is simple. The patient does not need to lie flat or change position as they would do if they had intrathecal chemotherapy, because the chemotherapy has been delivered directly into the ventricle, and the patient is fit to leave the department within a few minutes of completing the procedure, knowing that he's had no problems with previous injections.